Hello and good afternoon. I'm Dr. Hu Mei Lin and I'm representing OGSM today, and I welcome you to OGSM's Expert Series webinar, the second installation of the series. Thank you for taking time off your busy schedule to be with us this afternoon. Today our webinar is titled Manipulating Hormones Beyond Contraception. Now we conceived this webinar because, of course, as obstetricians and gynecologists, we do manipulate hormones for a living. And Dr. Premitha has helped to develop a very exciting program this afternoon. And we have managed to secure Dr. Anthony Siow from Singapore, who will share his experience with us. We are very lucky to have him today. So the aim of this series is to help you to tackle the common presentations to our practice, namely dysmenorrhea and menorrhagia. And the focus will be on the novel uses of the hormone preparations that are available to us today. So we have an exciting afternoon ahead, and a definite highlight for this afternoon would be the case discussions that will be happening later. Usually, I personally find that case discussions actually help me to enhance my practice because it is these common problems that we think are a no-brainer that will actually stump us in the end. So we also have a mechanism where you can ask questions or even present us with maybe your difficult cases for discussion, because we do have two experts on panel, so feel free to ask us the questions. And I hope that you will find this afternoon enjoyable. I would also like to record our thanks for our supporters today, Bayer and Dr. Shield, who without whom this webinar would not be possible this afternoon. So I would like to now introduce you to Dr. Premitha Damodaran, who will be talking this afternoon to us first. Now, Dr. Premitha is a brilliant consultant obstetrician and gynecologist who is attached to Pantai Hospital, Kuala Lumpur. She's been in the private sector now for many years. I won't tell you how many, but many years. She's an icon, really. And she has both continued to practice in general ONG, as well as sharpening her skills in hormone-related issues with women. Now, even with her busy schedule, she actually takes time off to sit on various councils. She's actually presently the chair of the menopause subdivision of OGSM, and she's already designed our menopause website called www.menopausefacts.org, and this was launched in October 2017. Sorry.
Enough.
Really, yeah. Okay, so without further ado, I hand the mic over to Dr. Premitha, who is my inspiration, actually. Okay.
Oh, wow. All right.
Carry on.
Thank you. Thank you, everybody. It's a Saturday afternoon. Usually I try and catch a nap. So I hope that this talk today wouldn't make you have a nap, and actually, you would be able to join us for a lot of the case discussions. The talk for today is the dilemma of dysmenorrhea. Let me just get my slides organized. Yeah. So when we talked about what interesting topics we would introduce in this seminar, one of the things that actually came up was the fact that let's talk about dysmenorrhea. Now, I don't know about many of you, but for me, during this MCO and when I was running clinic, a lot of mothers actually took opportunity to come to see me because they found that with the daughters being at home, they found that a lot of their daughters actually had painful periods. So today's topic is going to be a little bit about dilemma of dysmenorrhea in the adolescents. So in the adolescent girls, we're not going to talk about in the older women, but more in the time of, in the earlier ages, between say 13 to 20, because that's where the dilemma is. To walk with these slides. Dysmenorrhea, painful monthly periods. It is the most commonest gynecological problem, and it results in school absenteeism and poor performance. Now, it doesn't actually come on immediately. The first few years, 2 to 3 years, you could have anovulatory cycles. And these anovulatory cycles are not painful, but it's only later when the cycles become ovulatory, and that's when the pains may start. Now, it is really very common. And I like, when I was doing my research, I found this wonderful paper that came out in 2009 about the incidence of the prevalence of dysmenorrhea in Kuala Lumpur, in Federal Territory. And the authors of this paper actually looked at more than 1,000 girls in 15 public schools in the Federal Territory. 74% had dysmenorrhea. In about 51%, they said that it affected their concentration, it affected their social activities, 20% missed school, there was poor school performance, and only 12% sought medical care. The mothers were the most important source of information. So this was 2009. About 2007, 2 years before that, 2007, another paper that had come out before that actually showed that the risk of dysmenorrhea was actually highest in the 15 to 17-year-olds, and also very high in those with family history of dysmenorrhea. Now, a couple of years later, they looked at the rural areas to see whether it was any different. And again, studying about almost 1,300 girls in Kelantan, 76% dysmenorrhea, only 14.8% got help. And always remember, the mothers are the biggest source of information. So we know there are two types of dysmenorrhea. We know we have the spasmodic primary dysmenorrhea, typical, happens 2 to 3 years after menarche. You get crampy, colicky pains, which just starts maybe a few hours before periods, and then about 1 to 2 days, and then it goes away. You may have a backache. It can be accompanied by nausea, vomiting, diarrhea, headache, and usually no pelvic pathology at all. Why do we get primary dysmenorrhea? And this is all, the whole mechanism is due to prostaglandins. Through the cyclooxygenase pathway, leukotriene inflammatory pathway, there is excessive prostaglandin in the endometrial layers in the uterus. And because of that, you get dysarrhythmic uterine contractions, you get hypercontractility of the uterus, increased muscle tone leading to uterine ischemia. So all these are the factors that lead to painful periods, which are actually quite normal. Then you have the other extreme. You have the congestive secondary dysmenorrhea. This can happen about 10% of adolescents. But actually, when you sit in the clinic, you think it happens more, but it happens in about 1 in 10. The cycles now have become ovulatory. There's heavy periods. It can be irregular bleeding. There can be pain not only during period time, but it can be outside period time. Usually, now we have a pelvic pathology that we need to look for. It can be accompanied with fever, vaginal discharge, and if that girl is sexually active, she may complain about painful periods. Possible causes of secondary dysmenorrhea, of course, the number one problem is actually endometriosis. This is the most commonest cause of secondary dysmenorrhea. Next comes adenomyosis, fibroids. Let's not forget pelvic inflammatory disease, because these are questions that we need to ask the young girls, whether they're sexually active, adhesions, and of course, one of the most important things is that, is there a development anomaly of the Mullerian tract that's causing secondary dysmenorrhea? Now, a lot of girls come to us with pain, and it actually might be disguising other psychosocial problems, sexual assault, abuse. We need to remember that there might be a foreign body in the vagina. They might have, for some reason, put in an IUD, or are we missing out a pelvic malignancy? And remember, if there is any chance of a pregnancy, always try and rule out a pregnancy. We do not want to miss out an ectopic or any other problems. So, recurrent dysmenorrhea, pain month after pain. And I think that's where it gets us down. Because if we all, as a girl growing up, if I got pains once in a while, I'm fine. But if I take off 2 days in a month, with pain month after month, year after year. Now that's going to get me depressed. And that's exactly what we're looking at. We're looking at a lesser quality of life, decreased quality of life. It affects your sleep. It affects your physical activity, because then you start timing all your activities around period time. Everything during periods, you're probably at home. The mood suffers. The girl can go into depression. And then you get chronic pelvic pain. You get hypersensitivity to all sorts of pains. And this then really affects the girl in the long run. So who are these girls who can get affected with dysmenorrhea? And what studies have found are these are girls who have earlier menarche. Their cycles are longer. They have heavy menstrual flow. They may be smoking, and a lot of young girls are actually smoking these days. There is a positive family history, and this becomes significant because we know that if the mother has had especially painful periods, which could be due to endometriosis, then there is a very good chance that the daughter can get it. Obesity, because of its association with polycystic ovaries, can give you dysmenorrhea, but it's more of pelvic pain. Alcohol consumption, which may lead to dehydration, that too can cause there is some association with dysmenorrhea. But out of all these things, I think the most important thing that we need to remember is positive family history. Now, just a couple of days ago, I had one of my old patients coming to see me with her daughter in tow, who has just come back from overseas. The daughter's been having sudden dysmenorrhea from January onwards. Now, everyone thought because of exams and things like that, she was, stressed out. And there, lo and behold, is a 5-centimeter endometrioma. And then the mother says, yes, I had endometriosis when I was 18 and I was 25, and I had to get it surgically removed. So positive family history plays a very important role. But we need to talk to the patient. We need to talk to the girl and ask her a little bit more details. How long is a period? What is the duration? I mean, in the sense of what are the number of heavy days? What are the number of light days? Is there flooding? Are there night changes? When does the pain actually start? And when does it escalate? Does she have any other associated problems? Is she missing school? Or was she one of those who could go to school before, but now as time goes along, she's not being able to go to school? And delicately, because usually in these cases, mothers are around or any other senior family member is around, we need to try and get a history of whether she's had sex before or if she's sexually active. Now, this is a game changer because then you have to look at pelvic inflammatory disease. We need to ask her about medication. Now, a lot of our girls are following what the mothers tell them, and it's always herbal. You manage it with a hot water bottle, but sometimes they actually need tablets and painkillers. They might be only taking it at the height of pain and not as the pain begins. So teaching them about how to take painkillers is also very important. What I do normally with my patients is ask them about, try to grade their pain. And this is an old chart, actually came out in 1982. But this is simple because then we can sort of grade their dysmenorrhea into 4 parts. And, 0, where life goes on, grade 1, where life goes on most times, and grade 2, where it's really starting to affect you because now you may not be going to school, and grade 3, where it is now disrupting everything around you. So with this, you can also then see a change of how their dysmenorrhea has been over the past few years. So then we come on to examination. What can we do? What do we actually examine? And I think key is to put your hand on the abdomen to look for any pelvic masses. Now remember, mom's there in the room. You can't do any pelvic examinations unless you try and kick the mom out. And somewhere along the way, you have to ask them about sexual activity, as I said. But I think it's also very important, with the mother's permission, to actually look at the genitalia from outside. And if possible, in the sense that if there is a, if there is a consent, and if there has been sexual activity, trying to do a vaginal examination. Then comes an abdominal ultrasound, or if if she's not a virgin, then a transvaginal ultrasound to look for any problems that you can pick up. Now, this would be probably the basic part of examination and investigations. But of course, along the way, if she's been bleeding, you would like to do the full blood count. If PID is suspected, then doing STD profiles. If endometriosis is suspected, if you want to do the CA1 to 5, maybe it's a urine infection and you would like to see what's going on with the urine. And then comes the different kind of tests that you would want to look at when this initial tests fail or you can't pick up anything and you want to investigate this girl further. Then you would then look at the HSGs, the CT scans, or even the MRIs. But that would be going deeper into dysmenorrhea that you cannot actually pinpoint where it's coming from. And of course, then comes the definitive diagnosis. Again, very, very rarely done unless there is a reason to do it, to do an EUA, hysteroscopy, laparoscopy. Again, only if, if there is a development anomaly or you do see a huge pelvic mass, or again, as I said, when all else fails. So this would be sort of the flow pattern in investigating a girl with dysmenorrhea. So what can you do? Let's start off with non-pharmacological management. Simple things, you can put a hot water bag. It may help. But these are also girls who may not be actively doing anything. And this we found with the MCO, and I found it with my own patients, because Grab services were much higher, food intake was all over the place, there was no physical activity. As a result, periods got a lot heavier and more painful. Now, sitting in front of your screen, zooming for about 7 to 8 hours with school activity. Again, I also call it the bubble tea syndrome, because a lot of them were actually having bubble tea. And I found a lot of weight increase and a lot of periods that were changing. So telling them to get back into physical activity is very important. If that girl smokes, to try and cut down smoking. A low-fat vegetarian, a low-fat diet, more vegetarian diet may actually also help. And dietary supplementation with omega-3 actually has been shown to help you with dysmenorrhea. All else fails, get the TENS machine, use that to see whether that would go anywhere. Otherwise, it would be going on NSAIDs. And NSAIDs have actually have been shown to work for dysmenorrhea. There have been various types of NSAIDs, and we have them in the market. They act via the cyclooxygenase pathway. As we said just now, that the dysmenorrhea can come in through the leukotriene pathway, which is the inflammatory pathway, or the cyclooxygenase pathway. NSAIDs act via the cyclooxygenase pathway. It reduces the prostaglandin. You have less vigorous contraction of the uterus. But interestingly, the loading dose should be twice normal. So, for example, you are taking, mefenamic acid. Take double the dose to try and curtail it. Then it goes to a regular dose as needed. Of course, now we talk to anyone about taking painkillers. We have to tell the girl never on an empty stomach, and make sure that you eat regularly throughout the day, because that's really important for any form of NSAIDs. COX-2 inhibitors have also been approved, but usually for girls above 18 years. No response to NSAIDs for 3 to 6 months, we go on to the next level, which is oral contraceptives. Now, oral contraceptives not approved for dysmenorrhea, but widely used. How does it work? Your the endometrium is thinner. You have lesser endometrial lining. This then thus, because of this, the level of it sort of reduces the prostaglandins and leukotrienes. Inflammatory changes would be much less, and this then would cause you to have less painful periods. It also helps in other ways. It helps with heavy, irregular periods. And for a girl who's going to school and, she might have other sports activities or tournaments or swimming championships, it also helps time her periods. And she can use it to, to change things along so that, she doesn't have a period during these activities. She also may find it beneficial for acne and, if sexually active, for prevention of pregnancy. But we have the main issue with the oral contraceptive pill, which is what I call the mother factor. And that mother factor is very, very important. Now, I was trying to find, journals and articles about Asian mothers and what they thought about the pill. And the only one I could find was this Hong Kong article. The fact is that mothers do not like their daughters going on the pill. And, this might be a Hong Kong study, but it is applicable in this country. First of all, their knowledge of the combined pill is very poor. The next thing is they would think about the fact that, oh my God, my daughter is going to put on weight. The next thing is that it's going to say, can she get pregnant later in life? Will she get breast cancer? The pill, this is hormones. You are doing her more harm than good. And of course comes the winner of what they're going to tell you is the fact that I had period pains when I was younger. I got married and I had my child, and then it all went away. So this is what they are hoping for their children. And why would the child then need to go on the pill? And of course, they don't want their daughters to become sexually active because now they're on the pill, contraceptive benefits. And would that then give them that green card to have sex with with one partner or multiple partners? So this is what I call the mother factor, which is a very, very important factor. Other treatment options could be, giving them the depot, which suppresses dysmenorrhea by suppressing ovulation. It is usually long-acting, but we do worry about bone mineral density, so it's not very encouraged in the adolescents. Interestingly, the LNG IUS, the Mirena, is not commonly used in the adolescents, which I think is something that we should change with time, because I think it's great. The only thing would be how to put it in, and we might have to take the girl to the theater if she's not sexually active, or using the etonogestrel subdermal implant, the Implanon, which seems to be more popular for those who have got other problems in adolescents who mentally or physically challenged. Now, so you have this girl sitting in front of you and you think, okay, she's got primary dysmenorrhea. I think we can, try and talk to her about some medication, but this is how, this is what's recommended. That we shouldn't be just assuming that they, whatever type of treatment that we are giving them would work. So a follow-up becomes crucial. You start them off on NSAIDs or COX-2 inhibitors, just 3 to 6 months, call them back. Is it working? Is it not working? Move on, convince the mother for oral contraceptives. And usually if you tell your mother, you're going to try this out, let's see how it goes, she would be more receptive. If the oral contraceptive does not work, it's very important to now investigate her for secondary dysmenorrhea. Now, my mind's always trying to find a simple way to sort of sort things out. And this is what I did for you so that, you can look at your girl and then decide how to go about things. Now, getting to a diagnosis quickly. If one has painful periods right from menarche or even before menarche, having some pelvic pain, we have to think about developmental anomalies, vaginal septums, vaginal agenesis, all sorts of issues in the uterus. So we may have to look at getting an ultrasound done, an MRI done, and even going on to doing a hysteroscopy or a laparoscopy if necessary. Always remember that teenagers with early onset dysmenorrhea may have obstructive anomalies. And if one presents early with endometriosis, it should raise the suspicion for genital flow obstructive anomalies. Very, very important. So the younger the girl with endometriosis, the higher her chance of having a congenital an anomaly in the reproductive tract. If the pains get progressively worse with time, and the pains now start, the intensity increases, the pains are outside periods, we have to look at endometriosis, especially when there are other factors coming in. If she's sexually active and painful, or when she is trying to pass motion, it's painful, especially if there's family history of endometriosis. Now your mind would go on to ultrasounds and then talking about whether medical treatment would work for her, or are we looking at surgical treatment. If the pains get progressively worse with time, and now you have a period flow that is getting heavier with time, you find a pelvic mass. Now we're looking at uterine fibroids, adenomyosis, ovarian cysts. Again, ultrasounds, CT scans, MRIs, and then to talk about management, whether with hormonal tablets, a depot, implant, IUS versus surgery. So that would come in that discussion. But remember that there are other issues too. Inconsistent history of period pains, depression, substance abuse history, trauma, you get psychosomatic pain. Now, this is a girl that needs counseling. You might have to talk to her about painkillers, stop whatever drugs or whatever other substance abuse that she's doing, stop smoking. And here we have to do a one-to-one with the girl to try to get her onto the correct spot. But how about pains that are always there? You have this kind of niggling dysmenorrhea, but can't suddenly intensify. You have now pains which might be on the sides, on the adnexal sides. You get vaginal discharge, fever. We are looking at a pelvic inflammatory disease. And the most commonest STD that we're looking at is the chlamydia and the gonorrhea. So here you have an additional advantage of doing the blood test, getting the CRP done, swabs, and then looking at giving them antibiotics. And of course, here is a young girl with pelvic inflammatory disease. Don't forget the counseling and the contraceptive advice that would come along. Now, that was the first half of my talk. But what I would really like to spend the next 15 minutes or so is about the most commonest cause of secondary dysmenorrhea in the child or in the teenager. That is endometriosis. Now, endometriosis, many years ago, was called the strangulation of the womb because it is so painful. So here you have pain, and you have a recurring pain that comes on every month. Now, the youngest girl with endometriosis was 7 years old. And now, in hindsight, because we know more, we would think that that girl probably had an anomaly which should have been corrected, and then her life would have gone back to normal. But it is there, and we do find that endometriosis is underdiagnosed below the age of 20 years. This paper by Haas in 2012 actually showed that by 15 to 19 years old, there is about 2% of population of these girls already having endometriosis. Now, their risk factors would again be what I said just now, family history. Family history, very, very important. And always look out for obstructive type of Mullerian anomalies. And the good news is, once we correct that anomaly, there is spontaneous resolution of endometriosis. The sad thing is that girls with endometriosis and adolescent girls with endometriosis, their endometriosis is progressive. Their endometriosis have got deep roots, deep infiltrating endometriosis. And a much higher proportion of young girls have advanced disease. And this is the saddest part of the whole thing. So these girls come in with the classical dysmenorrhea. They may have acyclic pain. A lot of them have acyclic pain. A lot of them have dyschexia, constipation, intestinal cramps. They have pain when they exercise. They have pain when they pee. And they have pain even when they have sex. So this is a girl who's already starting off with a lot of pain. And it's there, we do get girls with, and the younger the girl is, it is there that they tend to have more serious disease. Now, Anthony may know this study because this is a study that came out from Singapore in 2017, when they looked at 45 Singaporean girls between the ages of 14 to 25, and they found that 71% had stage 3 and stage 4 endometriosis. The Korean study of 39 girls, actually between the ages of 10 to 21, found that 46% had stage 3 and stage 4 of endometriosis. So when endometriosis happens in the adolescent, they tend to be more severe. So let's try and look out for these girls that, you know, we don't want to miss the boat with these girls, because we know that most times, by the time they come to us and we diagnose endometriosis, they've already been doctor hopping for a few, they've already gone to a few doctors, and there's already been a delay. And the delay has actually been calculated to be even up to about 7 years. 7 years that we could have done something. But what do? Do we give them medication? Do we operate them? And that's the dilemma that's coming in with endometriosis in adolescents. Now, if I had a daughter who's 18 years old, I don't have a daughter who's 18, but if I do have a daughter who's 18, and I was told that she was having or she could have endometriosis, and I was told that I should be taking a pill and she should take it for long term, I would be hesitant. So I would know what the mother is actually feeling, because not all individuals are comfortable committing to years of medical therapy just based on history and examination. Sometimes we need to know more, because we like to know as mothers and as family caregivers, what would that medical therapy do? Would it make it worse? Would it really be good for them? How would it affect their future, and especially when it comes to fertility? Or do we then just go ahead and take out that disease part, take out the endometriosis, clear all the adhesions, and then try and give them some treatment? Or if they have an anomaly, correct that anomaly. Would all these things be better than just putting them blindly on medication? What are the common medication for endometriosis? We talked about the pill, but more and more, because endometriosis is an estrogen disease, it's estrogen-based disease, we look at giving them progestogens. And the progestogens that are most commonly given before was norethindrone, now we have Dynogest. We also look at giving them the possible implants or depots or the LNG-IUS, all progestin-based. Now, what about GnRH agonists? Now, these are injections that would completely suppress their FSH, LH. The only problem with this would be the fact that are we then making them lose a lot of bone? That's when we would talk about whether we should give them add-back therapy to help them prevent bone loss, because their bones are actually building up during the adolescence. There is also GnRH antagonist, which is Allegorix, which is available in certain parts of the world, and I'm not ever sure whether it's going to come this side or not. We hope so. But again, the question of bone loss with these girls are there when the FSH and LH is shut off. So let's look at oral contraceptives. Now, painful periods, anyone comes to you with painful periods, we would give them, routinely oral contraceptives. And let's say that painful period was due to endometriosis, especially deep infiltrating endometriosis, DIEs. Would we be doing the correct thing? What studies have now shown is that we might be making their DIE actually worse. Now, this is a study that actually, 410 patients were with histologically proven endometriosis versus 566 patients without visible endometriosis who were given oral contraceptives, and they found that the past OC users had a higher DIE rate. So are we again now doing more harm Why is it? Why is it that the COC was not working for these particular girls? And what we have come to realize is that the dose of that estrogen in the COC may actually be too high. Because if you look at the low dose OCPs, the estrogen content is about 20 to 30 micrograms, which is actually 4 to 6 times the physiological dose. And this is a tablet that is taken every day. So even during what should be the low estrogen menstrual phase, you are taking estrogen. And does that then actually cause more endometriosis? So are we doing more harm? Is the whole thing about oral contraceptives with painful periods, are we making it more counterproductive? Are we making things actually worse, and which results in estrogen dominance, especially in the presence of progesterone resistance? So this is what's coming up. So we also have to think about, let's maybe moving away from oral contraceptives. Do we just give them progestins? Because that might be the better first-line treatment for endometriosis. Now, we do know about Dynogest. We've all probably used it very, very frequently in the clinics, and I must say that I actually like the product. It is basically a progestogen. It is highly selective for progesterone receptors. It suppresses the estradiol levels moderately. It's excellent as an anti-proliferative and anti-inflammatory, especially in the treatment of endometriotic lesions. It takes away your pelvic pain and period pain. It's good and it's safe for long-term use with very less adverse effects. This study that came out in 2019, where they actually compared Dynogest and norethindrone, and they, on women who had endometriomas. And if you look at the size of the endometriomas over a 12-month period, the Dynogest and norethindrone actually worked very, very comparably. So doing very well to cut down the size of the endometriomas. But when we looked at other issues like dysmenorrhea, chronic pelvic pain, and dyspareunia, the Dynogest was way, way superior than the norethindrone in trying to cut down these other symptoms which these women actually, or these girls actually suffer. So it helped you cut down pain in all ways. Now, what about Dynogest for adolescents? Because we do worry about their bone. Are we doing again more harm? Now, this is a study of Dynogest on adolescents. This was a long 52-week study where they studied a lot of this. It was a multicentric, single-arm, open-label study in 21 centers in Europe between 2012 and 2014. And their main aim was to look at the BMD of the lumbar spine measured by DEXA. And BMDs were carried out at baseline and at the end of treatment. So the mean age of these girls was 15.4 years. The mean age of menarche was 12.1, and it was found that their estradiol level dropped by about 30%, which is what is expected. 50% of them, pain disappeared by week 4. There was definitely a change in the BMD by about minus 1.2%. But the good news is for about more than almost all of them, there was recovery after 6 months. And a lot of them went back to baseline. And this study was only for that 2-year period. And we will we all hope that, if the study was actually continued with time, the loss was all, they recovered all the loss when they were put on the Visan. Now, whatever it is, what I think we should always do when we are looking at giving Dynogest for the young girl is that we need to think about her bones, and we need to then talk to them about exercise. We need to talk to them about going out in the sun, getting that vitamin D in. If they're smoking, to stop smoking, So basically looking at a healthier lifestyle, looking at taking calcium-rich foods, which will also aid in improving bone density. Laparoscopy has been always carried out as the last choice for diagnosis of endometriosis, and up to about 70% of adolescents with chronic pelvic pain actually have endometriosis. It is the gold standard if all your medical treatment actually fail. Now, morphology is different because you have more red flame lesions than older powder burn lesions. The peritoneal windows and defects are more common, and there are more clear, shiny peritoneal vesicles. But do we take out that endometrioma if you see that endometrioma during the laparoscopy? Does it make it more, do we worsen the existing ovarian reserve? So that becomes that big question mark that is becoming, that is a question that we really need to ask, and whether we should reserve doing a laparoscopy and a cystectomy only for those with large endometriomas or who have pains that are not responsive to medication. So always think about ovarian reserve with the laparoscopy, because we are looking at adolescents and we are looking at young girls who are one day going to become mothers. So the current management for endometriosis would be medical first, and we're looking at progestins, and then coming into surgical management where there is no response to medical therapy or when there is an infertility question coming up. Now, the lifelong journey of a young lady with endometriosis or with dysmenorrhea, it's a long, long journey because, you know, she's going to go through school, university, work, and then she's going to start, you know, get married, have a family. It's a long journey of pain. So when we treat an adolescent, we need to think 30 to 35 years ahead. And with that, thank you very much.
Thank you, Dr. Premitha. It's been a long time since I've been so riveted and paying so much attention to a talk. And I think certainly I do agree with you. We do need to sort these young girls out. So I hope that everybody has benefited as much as I have. So for our next speaker, it's Dr. Anthony Siow. And I've had the privilege of actually being Dr. Anthony Siow's mentee when I went to be attached to the MIS unit in KKH in Singapore. And I must say that he has always been a brilliant surgeon. So I cannot operate like him. He's brilliant. Okay. And then he's always been a tech head. He's always had the most up and coming technology on board with him. So today we're going to enjoy that with his presentation today. But on top of all that, he is the medical director for ASC for women at Gleneagles Medical Center in Singapore. We're very privileged to have him today. He is a very busy and much sought after speaker. And I do guarantee that I did pull some strings there. So he has had more than 20 years of institutional practice and was the first director of the MIS unit in KK Women's and Children's Hospital. And it is there that I actually saw how he performed a single port laparoscopy, and I was very, very much inspired by that. And he's then gone to do that around the region as well. So he also does obstetrics, although he tells me that he has stopped, much to the dismay of many Singaporean women, I'm sure. But on top of all that, he is a great teacher and a wonderful mentor. And oh, Anthony, there's just so much love for you. Okay, all right, okay. So he'll be speaking to us today on the management enigma of adenomyosis, which is a nightmare to all of us. I always call adenomyosis the evil twin of endometriosis, and he's always stumped us all what to do for these women, especially in women of childbearing age. So, Anthony, over to you.
Thank you. Thank you. Welcome, everyone, to this afternoon's lecture. Let me just get my slides up. So we're going to talk about the management of adenomyosis and focus mainly on the medical treatment, because we all know the ultimate treatment is surgery. But in younger women where the womb needs to be preserved, then medical treatment is our only avenue. So it's actually been described like a cancer way back in 1860s when Karl Rokitansky coined the term cystosarcoma adenoid uterine. And so at that point in time, nobody knew what it was. The term sarcoma came out, but we now know that it is actually a benign condition of ectopic endometrial glands and stroma within the muscle. And so it's like endometriosis inside the uterine muscle. It can be diffuse all around, or it could be focal like a fibroid. But unlike the fibroid, the ultrasound features will have very poor defined edges and sometimes abnormal blood flow. And most of the time, it causes the whole uterus to be enlarged to sometimes a great amount. We all know the definitive diagnosis is by histology, but of course, that only is going to happen when you take out the uterus or do a adenomyomectomy. But sometimes we have to suspect this condition based on the symptoms, ultrasound, and MRI, which Premitha has gone through in great detail. So there are many ways to classify adenomyosis. This is one of the more elaborate one, where they look at it being in the diffuse outer or inner region, or focal outer or inner region, where you can classify as mild, moderate, severe, depending on how deep, how many walls are involved. But really speaking, it's really very complicated to use this in clinical practice. And so most of the time, we use our transvaginal ultrasound, and we look at whether it's globally involved, whether it's asymmetrically involved. Sometimes we can see cysts and hypoechoic islands. The most common one is we see all these ray of lights coming out because of the blood clots harboring in the myometrium layers, preventing the ultrasound shadows from going through. So this is quite common of adenomyosis. We can also see it near the junctional zone where there is stripping or abnormal vasculature, or sometimes even the whole junctional zone being thickened or lost in some area. And so on ultrasound, you can see all this stripping down here and the abnormal blood flow. And sometimes with very good transvaginal scan, you can even see this. So looking at this, you can actually see what this is all about on hysteroscope. You can see these are the holes going into this area. And so when you do a hysteroscope and you see all this, then we have to suspect that there is endometriosis in the wall, which is actually adenomyosis. And so that's what we generally see on ultrasound. And sometimes if that's not clear enough, we do MRI. And MRI also has got it in terms of the internal, the external, or even in the adenomyoma. And also there's the diffuse internal ones, there's the diffuse external ones, and sometimes there's the focal internal ones, and then the focal external ones, like in the back, in the front, on the serosa region. And so really speaking, if you use MRI, this will be probably what we are looking at, that it is normal, maybe diffusely all over the uterus, and maybe a little bit on one wall that is focal in nature. So with so many ways to classify adenomyosis, the ultimate, it is still histology. But even with histology, look at the number of doctors and over the years what they have tried to classify it as. And so there's really no one way to classify endometriosis. Some look at percentage of depth, some look at centimeters of depth, some look at proportion of depth. It's a real conundrum of whatever things you can come up with. And so in the latest review on the classification and reporting systems of adenomyosis, Monroe actually says that it is still a work in progress. And even when you look at histology, different sectioning techniques can give you different sensitivity. And behind all this is that there are adenomyosis that are asymptomatic, and therein lies the enigma of adenomyosis endometriosis. And so a cause-effect relationship between what you see and what the patient has may not be always there. And I always feel that we should always treat the woman and not what we see on the picture or even what we see on the CA125. If we see a lot of adenomyosis lady, the CA125 can go way up to 600, 900 to even 1,000 plus when she has an episode of severe pain. With no ovarian pathology, we shouldn't be jumping and start to treat aggressively the adenomyosis. When the pain disappears, the CO125 will come down. So we still have to treat the woman rather than the picture we see or the CA125 we have. So is there a way then to see whether certain adenomyosis give you certain symptoms? Well, Katerina has tried to look at this 108 women, and she kind of classified it as, we know the diffuse adenomyosis happen more in the older age group and the focal ones a bit younger. But she found that if you have adenomyosis in the outer aspect of the uterus, it tends to relate more to pain at periods, pain at sexual relations, and also fertility issue. And I suspect this is because when adenomyosis is closer to the outer, it is also linked to pelvic endometriosis. And so certain treatment will then work better than others, certain medical treatment will then work better than others, and certain medical treatment will fail. And so if we see it very affecting the junctional zone, then miscarriage is something we have to grab with. And so really speaking, Kishi from Japan also has subtyped the adenomyosis to those that is closer to the internal, and subtype 2 and 3 to be those to the external. And over here, you probably can see it being adhered to the rectum. And so the external adenomyosis tend to be related to maybe pelvic endometriosis or rectovaginal septum endometriosis. And so those has got implication in what medical treatment we apply. So the medical treatment, if you look at all textbook, we'll run through so many of them. In a lecture, this is going to be really boring to go one by one to tell you what one can do and one will work. And so I think in this talk, we should stay away from such format. And I would be more practical in the sense that after taking a good history and examination, the transvaginal ultrasound will be the one that kind of tells us what will work and what will not. And let's talk a little bit on the Vizen, the Mirena, the birth control pills, the GnRH, because these are what we normally work with, and these are mostly accepted in the general practice. And we probably go a little bit on who needs what, which one works in which patient, and finish off with a little bit of novel treatment in the front line of adenomyosis. So let's start with Vizen, because it is the medicine that is targeting endometriosis, and I do believe it has some impact on adenomyosis. And I always refer to this paper for long-term treatment of endometriosis. This is actually a small paper of 18 patients, but what is about this paper that always attracts me is the duration of treatment that they give till menopause. And so the patients in this paper took Vizen for close to 7 to 8 years, as you'll see how. And so the number of patients are grouped into those that have completed to menopause and are still taking, and a few of them discontinued because the bleeding just couldn't stop. And some of them had severe side effects. If you look at the patient profile, you will see that most of them are of the same age, roughly. But what is important here is that some of them are taking for close to 7 to 8 years and has no adverse reaction. So if you use Vizen for adenomyosis, there will be some that do not work and some that carry on. So who are the likely women that Vizen will work for? So in this paper, he divided into two groups, those with not so severe pain score. So by the time it is so severe pain score, maybe the disease is too advanced for Vizen to work. those with no severe bleeding, normal, relatively normal hemoglobin, not too high CA125, and very importantly, those with outer uterus adenomyosis. So if we were to choose a patient with Vizen, try not to use one with a very big uterus, with internal adenomyosis, with low HB, the bleeding may not stop with Vizen, and one with a CA125 is always very high. Okay. So let's go on to Marina and the birth control pill. There's actually a good RCT done in Egypt by Shaban. He actually looked at all the patients with pain in a clinic, and they were aged between 20 to 45 years old. And the diagnosis of adenomyosis is by ultrasound, looking at the global enlarged uterus, some asymmetry and some cysts. And he offered them medical or surgical treatment. And it is quite enlightening to know that only about 43% would choose the medical treatment. So regardless of how good the medicine is, some patients will still not want it and want surgery. So we got to keep this in mind, that the patient choose what they feel comfortable with after our counseling. And so if they want medical treatment, it is either 6 months of Mirena or Gynera, and then because they came for pain, so the primary outcome would be pain. And so with Mirena, the pain reduction is actually quite good. The abnormal bleeding reduction is also quite good. And the number of pain-free days actually is high compared to the Gynera OCP. And so Mirena and Gynera both reduce the pain and the bleeding, but the Mirena is better at doing it. 72% versus 40% for pain, and abnormal bleeding of 73% versus 45%. So of course, overall satisfaction favors the Mirena. And when they measured the uterus size, they found that in those patients using Mirena, there's a slight reduction in the uterus size and the vascularity. And I think that translates to the reduction in pain and bleeding as well. What about if we compare the birth control pills with Vizen, with GnRH? Because we know that GnRH is the one that will stop everything, okay? And so this is done in Japan, and it is actually a retrospective study to, first of all, look at uterine volume, because Matsushima feels that the ultimate treatment of adenomyosis is surgery. And if we can do laparoscopic hysterectomy for a smaller uterus than a larger uterus, the risk will be smaller. And so if we can make uterus smaller, maybe that would be a good pre-surgical treatment. And so the diagnosis is by MRI, but the measurement of volume during the study is through ultrasound. And this is actually a very good formula to just look at volume. You can apply this to uterus, to fibroids, to cysts, and then use volume as something to follow up on rather than size, because the size may not be as accurate as the volume. And so for 16 weeks, some are given a low dose GnRH. This is half dose of a month. Usually our 1 month dose is about 3.75, but this is only 1.8. Another few were given cyclical birth control pills, and then the rest were given Vizen on a daily basis. So he only managed to get 26 patients for GnRH, 15 for birth control pills, and 11 for Vizen. So this is looking at uterine volume. So the first result, uterine volume, of course, dropped. But what is 330 cc? Well, if you look at this formula, it comes out to about 13 by 8 by 6. So this is a roughly moderate sized uterus. You probably can feel it just above the suprapubic. And when you say reduction to about 180 to 200, what is the size? And if you use this formula again, it's about 11 by 7 by 6. So slightly bigger than normal. And so the GnRH significantly reduced the volume over the OCP and the Vizen. But he also looked at secondary findings. And so this is looking at bleeding. Of course, there's no more bleeding after GnRH before and after. Pain, of course, we know GnRH reduced the pain very well. So it improved menorrhagia and pain with some side effects of GnRH, of course. But the birth control pill didn't do as good a job as the Visan. And so really speaking, this is adenomyosis. And so Visan might still be pretty good because the uterus is not very big to start off with. And so overall efficacy, GnRH is better than OCP or Visan. All right. So really speaking, Visan, Mirena, OCP, GnRH, and the comparison, who will be good for what? Okay, who needs what? So I think easiest if you look at GnRH, everybody can get GnRH if you can withstand the side effects. Okay, it will reduce the size of the uterus, reduce the pain, reduce the bleeding. We can't really use it for more than 6 months without add back. And so if you are thinking of pre-op, this is good. Catching up the hemoglobin count, this is good. Stopping acute phase pain, which is good. But we have to be mindful that every time we give GnRH, there will be a flare-up effect in 2 weeks. And so there usually is a bleeding 2 weeks after the injection. And if we didn't time the injection properly, if we gave the injection in the mid-cycle, and 2 weeks later her periods come together with the flare-up, the bleeding can be quite severe. So I normally give my GnRH after periods so that there's not much of a flare-up, and I always pre-warn them and give them some tranexamic acid to stand by in case the flare-up is quite big. What about Visan? Visan is good if it is not a very big and severe adenomyosis, and it is good if it is at the outer uterus, because Visan is systemic. It can also help with pelvic endometriosis, and so together it probably will help reduce outer disease, meaning outer adenomyosis or rectal vaginal disease or pelvic endometriosis, and it probably worked pretty well for those with not very, very severely high CA125, meaning not very severe endometriosis. What about the Mirena? The Mirena, being inside the uterus, will probably act pretty well for inner disease. And so those with strips, those that you saw on the hysteroscope just now with pathology near the endometrium, they will probably work pretty well with the Mirena. Okay. So what about pregnancy? Because all this medicine is not going to make her pregnant, yeah? So if she wants to get pregnant, you either try this medication for 6 months, get the endometriosis quietened down, and then try to get her pregnant again. Or do we have any other options? So adenomyosis and IVF, there are 2 good papers here. One is by Nui from China, and he looked at only frozen embryo transfer after downregulation. So the first day, GnRH, 28 days later, another half dose GnRH, and then at 21 days later, so that's about 7 weeks. 7 weeks of GnRH, then estrogen is started with 2 milligrams for 5 days, 3 milligrams for 5 days, 4 milligrams for 5 days, and then making sure that the EC, the endometrial thickness, is 8 millimeters. If it is not, another 5 milligrams for 5 days, and if it's still not, then you cancel the cycle. So if you can get 8 millimeters, then vaginal uterus gestant for 4 days before fresh embryo transfer. And he found that those with downregulation, then the estrogen and progesterone HRT, so this one has no downregulation and this one has downregulation, it's got pretty good implantation rates as well as clinical pregnancy rates, statistically significant. So a period of downregulation of up to about 7 weeks before works well for the pregnancy. What about PAC? PAC looked at the fresh and frozen embryo cycles, and this is a retrospective series. So fresh cycle with pre-cycle GnRH, or frozen cycle with pre-cycle GnRH. So if it is downregulation, 2 to 3 months of downregulation before embryo transfer, although they are not statistically significant, there is a tendency that frozen cycle with downregulation gives you a higher pregnancy rate. So are there differences with regards to the adenomyosis and the pregnancy rate? And so this is the frozen cycle with downregulation versus the fresh cycle with downregulation. And we found that those with focal adenomyosis tend to be doing better than those with diffuse. And this stands to reason because the disease is probably not globular. And if it is just one small area, some downregulation will make that small area ineffective to affect pregnancy. And so you can get this kind of result. But these 2 papers tells us that if we downregulate adenomyosis before we do transfer, they can get quite reasonable pregnancy outcome. So a lot of times, those patients who want pregnancy, I would downregulate them for up to even 3 months before I send them off to the IVF. So that's pregnancy. What about those cases where none of this work? Are there novel treatment on the horizon? So I was looking at this aromatase inhibitors. So we know that this is something we use for recalcitrant endometriosis. And we also use this in breast cancer patients for long term, for years sometimes. And so this is a RCT to look at aromatase inhibitors on adenomyosis. I can't find much about how they recruit the patient. They just said in this time frame, 38 patients were recruited based on ultrasound diagnosis of adenomyosis, age between 18 to 42 years old. And they were treated for 3 months with letrozole or GnRH, 1 injection per month. And after 12 weeks, they were looked at again. So if you look at the baseline, something that caught my eye was that almost 80% didn't have any symptoms. So it begs the question, why are we actually treating them? Maybe because it is the ultrasound that shows that it's a little bit big. So it goes back to my question, if you don't have much symptoms, I sometimes don't treat what I see or what the CA125 is. But no doubt this is a paper that's already done. And so what is the result? The result shows that aromatase inhibitors and GnRH both reduce the size of the uterus. So maybe that you can use letrozole to reduce the size with less side effect than the GnRH. So from about 12 centimeter uterus down to 8 centimeters, quite reasonable. And other symptoms like symptom improvement of pain. So this is 12 patients before treatment having pain, and then 10 patients with symptom improvement, compared to GnRH, where there are 13 patients with symptom improvement. So this menorrhea, 4 patients symptom improvement, 4 patients bleeding symptom improvement. Of course, GnRH, all the patients improve. So if you look at this, it does look as though the letrozole is not as good as GnRH, but when they did the statistics, it's not quite significant. So both are as good in terms of symptom control in this paper. What struck them was that there were 2 patients here that got pregnant with letrozole, and the babies were okay. And so really speaking, this might be one avenue other than downregulation and IVF to see if your patient get pregnant with letrozole. Because letrozole drops the estrogen on day 1, there's no flare-up as GnRH. And we know that it is used in those recalcitrant post-hysterectomy endo pain because sometimes it is the peripheral conversion of estrogen, especially in the bigger sized women, and they don't respond so well to GnRH. So letrozole gets into the fat to cause the aromatase inhibition, so the estrogen is low. And so if you use it for long term, it can cause bone effect. And so long-term use of letrozole with progesterone has reduced that bone density effect. So this might be a good alternative, letrozole, for patients who cannot take the rest of the medication. What about danazole? Danazole has been an overlooked option for rectovaginal endometriosis, the kind of endometriosis that's hard surgery to do, hard to treat, but very debilitating. So this is 12 studies looking at that, and I found 2 papers here, Igarashi looking at adenomyosis. And so this is his paper regarding danazole-loaded IUCD. So it's something that he created from his initial study in 98 about danazole vaginal rings. And so he used this for rectovaginal septal endometriosis and adenomyosis. And what is good is that the dysmenorrhea, within 1 to 2 months, patients start to get a reduction in pain and disappearance of the symptoms by about 3 to 4 months. Same for tenderness in the pouch of Douglas. Within 1 month, start to reduce in pain and then disappeared. Nodularity as well. And then 17 out of 31 patients got pregnant despite the danazole ring. So is this scary? Not really, because the danazole ring, although it's 1,500 milligrams, the serum danazole level is so low. It's less than 30 compared to if you take oral danazole of 400 milligrams a day, it can be this high. And so really speaking, the danazole level in the blood is very low, so much so that they don't even inhibit ovulation and you can get pregnancy. So how does it work? It works very well within the 1 month, absorbed through the vaginal mucosa to reach the deeply infiltrative endometriosis. So you get very low danazole levels in the blood. Pregnancy is possible, and it inhibits the DNA synthesis and cause apoptosis of endometriosis. So it's very good for rectovaginal septal endometriosis because it's right in the vaginal vault that you put the danazole. And so if the adenomyosis is not there, or if the ovarian cyst is not there, not near the rectovaginal septum, then it might not be so effective. There's also an interesting paper on vaginal promocryptin to help pain from adenomyosis, and this is because of the prolactin level in the uterine wall that is produced there because it's central to adenomyosis pathogenesis. And so 6 months of vaginal bromocriptin at 5 milligram dose in this paper improve the health-related quality of life scores, reduce the severity of symptoms. It reduced the bleeding, the picture bleeding assessment chart, but it's still not enough because normal should be 10, and this is still higher than normal, but much lower than when it started off. And pain-wise, not much. So although all the quality of life questions are showing a positive outcome, on practicality aspect, I think they're still bleeding and in pain, so may not be that great. And then there's valproic acid. This is an anti-apoptotic drug, but it is a very, very good histone deacetylase inhibitor that suppresses the endometrial stromal cell proliferation and cell cycle. And so in a pilot study looking at 12 women with moderate to severe endometriosis diagnosed on symptoms, examination, and ultrasound, 500 milligrams of valproic acid 3 times a day for 3 months. And 8 out of 12 women reported no pain after 3 months of the medication. So pain score dropped a lot, but bleeding still about the same. So the author mentioned that the safety of valproic acid shouldn't be questioned because it's been around for decades and people use it for long-term use. And if it can reduce pain, why not? Okay, so that is all the medical treatment that I'm going to touch on, except maybe this one, which is the new kid on the block, oral GnRH antagonist, elagolix. And so there is actually an oral presentation recently about it acting on patients with endometriosis and adenomyosis. So the objective of this paper was to see whether it works for a subgroup of adenomyosis. And it's a very complicated way of looking at things. They had one cohort of 32 patients on this dose, and the second cohort on a higher dose. And in each cohort, they split into 4 groups, taking placebo, the medicine itself, the medicine with a low dose hormone replacement, and the medicine with a high dose hormone replacement. And so it's really, really complicated. So you have got 8 groups of patients at the end. And the end point is to look at whether the bleeding is reduced by more than 50% of the menstrual blood loss. Well, the results is like that. Cohort 1, placebo, of course, don't work very well. Only 2 to 4 patients have relief. The medicine itself, close to 90%, 80-90%. But if you add the hormone replacement, possibly to reduce the side effects of the GnRH antagonist, you have even better menstruation control. So maybe this hormone also help in reducing the menstrual blood loss. So the conclusion, a higher proportion of elagolix treated women with fibroid adenomyosis had reduction in menstrual blood loss. So maybe this is a new drug on the block that shows promise for adenomyosis and heavy bleeding. So these are all the medication that you can use for adenomyosis. I think we have to choose the patient correctly, look at the symptoms, then look at the type of adenomyosis in the uterus, then choose the right medicine. So with that, thank you very much.
Okay, that was brilliant, Anthony. For Saturday afternoon, I'm still awake. That's great. But I think I've learned quite a few things. I'm really impressed with that Danazol IUD. I'm impressed. Okay, so maybe we'll move along now to the case discussions. Clarence, if we can have the e-studio open, please. Does anyone need like a little break? We've had a break. Does Anthony need a break? Anthony, do you need a break?
No, it's okay.
It's okay. All right. Okay, so we've come to the more exciting part of the case discussions. Now, interspersed with the case discussions, we will actually have a public poll where you can actually put in your opinion. And what we want to actually find out is what you would do as a doctor and to treat these women at certain points. So if you're using a laptop, then you can just simply scan that QR code and it will take you to where you need to go. If you're using a mobile phone and you can do a split screen, then you can just go to www.slido.com and put in hashtag OGSM0808 to join the polling. So the polling is just, it actually helps us because, you know, we can't see you, our participants today. And as a speaker, I often like to look at the participants because then I can gauge whether I'm boring you, you're still awake or not, or, you know, but some of you might be in home clothes or not wearing many clothes, so maybe we don't want to see that. So please don't turn on the video either. All right, so let's go on to the case discussions. We've got 2 cases lined up. We also have a couple of questions later for our speakers because someone's asked a few questions. So we'll go to the questions at the end. But in the meantime, if any of you would like to ask our speakers some questions, please feel free to type onto us and we will be able to field the questions for you. So the first question, the first case that we're going to look at is Aisha. Now, Aisha is a 17-year-old girl who has come to see you, and she attained menarche at 12 years of age, and her periods have largely been normal until about 6 months ago. Then it started to go a little bit crazy. So she's in the past 6 months, she's been having increasingly painful periods, and to the point that she's needed to take time off school, and it's actually affecting her academic performance. She's come with her mom, who thinks that period pains are normal anyway, and you know, hers went away after she had her first child. So, and this is actually quite a common scenario that I see in my practice as well. So I don't know if Premitha and I are just seeing the same cohort of patients, or do you experience the same thing, Anthony, where you know you have period pain and you have the mom who's really doesn't really want very much. So what would you guys do for this Aisha if you're seeing her?
Who, Anthony or Premitha?
Maybe we'll start with Premitha.
No, this is actually the typical patient that comes to us, isn't it? Looking at her, she's got period pains that are now sort of grade 3, grade 4, affecting her life. I would also like to take a little bit of history about what's been going on in her life, whether there are any other stresses that have actually caused the periods to get worse, especially the exam years. Whenever they are in those big board certificate exam years, they tend to have more stress. And because of that, their lifestyle has changed, period pains get worse. So I think I'd like to get a little bit of history about that first. But what is really at the back of my mind is the fact that her mom also had period pains. So, I have to keep that at there and, and worry about that particular part of it. But the mom also now finds it significant, even though mom had period pains, mom still finds it significant to bring the daughter along just for a checkup. So I have to keep all these factors in mind. I would examine her, as I said just now, history, examination, do an ultrasound, make sure everything is okay. I would probably then talk to her about painkillers and how to take those painkillers, and say it so talks to, starting off their doses and how to take it regularly. And then I would go from there. But I think one of the most important things I would emphasize for these children, and especially for their moms, is that this is not a one checkup that ends there. And I think it's very important for them to get a regular follow up, because if we don't see anything on the ultrasound today, would we see something on the ultrasound in a year's time or in 2 years' time? And I think that's really very important, that they need to be followed up. We need to know, has the painkillers worked? If the painkillers haven't worked, can we go on to something else? And I think that's where I would like to sit down and talk to the mom and the daughter about.
Anthony, how about yourself? You mentioned that actually we don't treat the picture, we treat the woman, and actually we do train our medical students and our trainees that way, that we actually we treat the woman and not the scenario. So in this case, like, there is symptoms, but usually when you do an ultrasound and all that, and often you can't do a vaginal examination because at 17 most of them are not sexually active, or if they are, they wouldn't admit that to you. What do you do then? Do you treat the woman even there's nothing on the picture?
Yes, I always try to paint a picture of what can happen in future for them. And with the mom there, it's sometimes quite easy to impress upon her about the daughter's fertility. So I'm sure at the back of the mind, they're always wondering whether they can get pregnant and all those things. And so from data, we know that young ladies with dysmenorrhea, close to about 60 to 70% is actually endometriosis, and 30% is actually normal. I mean, you can't find anything wrong. It's just normal dysmenorrhea. So I always start off by telling them that this can be normal in 30% of the time. It's positive and it might not affect your pregnancy. However, if you are the unfortunate 70%, then there is a chance that it progresses and you can have impact on fertility. And once they get that in their head, they are a bit more amenable to treatment. And I support that by trying to pick out certain pointers of secondary dysmenorrhea or abnormal pain that they tell me. So we know that endometriosis most of the time affect the left side rather than right side. So if they tell me they have more left-sided pain, then I can use that to say that that is one point for endometriosis rather than just normal pain. And I can also ask whether they have tried medication that does not make the pain go away. And so that's another point that tells me that there's endometriosis. So along the way, when I pick up all these nuggets that points towards endometriosis, I'll impress it upon themselves that this is possible endometriosis here. I don't need to do a surgery. And I think you might want to consider treating the endometriosis rather than treating the pain. Because even if there's no endometriosis, long time ago, the RCOG guidelines also gave this statement saying that for chronic pelvic pain with no other reason, progesterone is still the way to go. And so with progesterone that is so effective now, Vizen being so targeted for endometriosis and being so safe for long term, I would say give it a shot. All right. And then I would use the example of the mother. If the mother have endometriosis pain, and then she says she got it, she got pregnant and the pain went away, then I'll say, yes, that is what endometriosis can be. in the 1 year, 9 months of pregnancy and the 6 months, 9 months of breastfeeding is almost like 2 years of medical treatment. So if you take Vizen, our aim is maybe just for 1 to 2 years, like a pregnancy. And then like your mom, if the pain goes away after pregnancy, then maybe like you, after the Vizen is stopped, your pain goes away. And so it's not like forever you're going to take this medication. So if I paint it all like this, saying that it can be normal, maybe it's endometriosis, but if endometriosis, it might affect fertility. And if you want to take the medication, it's very targeted, very little side effect, very safe, but not forever. Maybe they'll be more agreeable to go on medical treatment.
Premitha, we live in a society now where, alternative medicine is seen to be a lot more safe than the
Bomo
Western
and
medicine
Sinte
that
have got
they
stronger
prescribe.
voices.
So are there alternative remedies that actually work, like taking turmeric or curcumin, or, are there anything that you found that actually works?
There's always a placebo effect, isn't it? So
Yeah.
everything has got a placebo effect. So it works well and good for you, but that just takes away the pain, but she still needs a checkup because you don't know what's actually happening underneath all that. So, that I think that's where the importance, and that's why I said you need a follow-up. It's not one checkup and you solve your issue and that's it. Cannot.
So
So
would
you
it be
can take
fair to...
anything you want. You can take anything that you want, but you still come back and see your doctor.
Correct. So I think we get the gist. But would it be fair to say that we always have to think that, could this period pain be something more sinister like endometriosis, and almost work like an advocate for the girl in the future, because she might then damage everything and not be able to get pregnant later in life. Anthony, what do you think about this statement?
Well, the data about progression of endometriosis is again quite enigmatic. There is no one study that says this percentage of endometriosis will progress. In fact, there are studies to even say some regress. And so, and the thing is, we all have seen patients where we have delivered them, and then they have some pain, and we do a laparoscopy, and lo and behold, the pelvis is so damaged by endometriosis, you wonder how they got pregnant in the first place. And so, again, it is not what we see and what we treat. So really speaking, if they are still not agreeable to take medication, then I would say live healthily. And we know it's an inflammatory process. And so things that are anti-inflammatory, exercise, taking all the antioxidants, stay away from all the bad food, like what Premitha has said, smoking, alcohol, those things. Those anti-inflammation things like turmeric, CQ10, give it a shot. At least you reduce the inflammation in the pelvis, and hopefully that doesn't make things worse with years to come.
Okay, so we'll move on. Terence, can I have the next slide, please? Okay, I meant to have done this earlier. I'm sorry, I just got so excited. But guys, everyone out there, this is the quiz now. So what would you do? Just disregard everything that we have said. So just show us what you would do. Please poll. So at www.slido.com, or you can just snap it on the thing. I think Malaysians tend to be a little bit shy. So maybe we'll come back to the poll at a later date. So guys, this works, but we will just move on to the next slide now, please. Terence, may we have the next slide, please? Thank you. So Aisha is now 22, and she's now attending university. But she finds that during her periods, she just can't even get out of bed because she's curled up on her bed in a lot of pain. And she now experiences bloating prior to her periods. There's also pain when she defecates, but only during her menses for now. And she's become sexually active, and when she does have sex, she does have deep dyspareunia. Next, please. Oh no, go back. Sorry, go back. Okay, so what now? Clarence, please go back one slide. That's the next slide. Sorry. Yeah. What now?
What now is endometriosis. And I think right now, besides just talking to her and examining her and doing the ultrasounds, would be to have a serious chat about medical treatment. At this point, medical treatment, and the fact that, as Anthony says, emphasize the fact that this is going to be treatment that's going to help her, with her pregnancy later, and she has to do something about it. The only issue here comes is the fact that she has deep dyspareunia, and whether there's already DIE and how effective a medication is going to be, but it is still progestins, and I would actually recommend Dynagest for her.
What about you, Anthony?
And can you take it? Yeah.
I might give her the option of Marina because she's sexually active, and so we know Dinogest you hardly get pregnant, but Marina is more birth control, and I mean it's in that sense that hopefully the deep Marina will go away with the Marina as well.
Now, for this girl, I guess your Danazol IUD might work a treat for her.
Yes, it could.
Seeing
It
as
could.
how she has
That,
maybe a
that
rectal
Danazol thing was
endometriosis.
very interesting. It was really
Ah.
interesting. The Danazol IUD and the vaginal ring, you know, because Danazol
Yeah, but
has
you
so
can
many
use
side
the
effects.
normal tablets. The normal tablets you can use it, and it's just inserted in. It works just as well. Yeah. In fact,
Oh.
the first person who told me about this was Professor Delphine Tan when I was in Philippines giving lecture. They use quite a fair amount of it, and it works very well.
Oh,
I've
okay.
never heard
That
of
is
it. I've
very
never heard of it
interesting.
until today, and I thought it was really interesting.
Okay. Now, okay, I'm going to put a spanner in the works now because she is 22 and she's a university student and she's sexually active. Now, usually you don't have just one partner at 22 and you're at university lah. So would you still advocate the Marina then? Would you not be worried about STIs?
Yeah, so again, the data for IUCD and PID, it's not that the IUCD causes PID, it's the multiple partners. So with or without the IUCD, you get PID with multiple partners. And so the misconception with IUCD increasing PID was because the first study of IUCD was done in Africa. You know, when they studied the IUCD, I met the person who pushed the study in Africa and said that there are lots of infection with IUCD in Africa, so they always give antibiotics before, during, after insertion, all those things. But when they repeated the same study in China, there are no PID, and because the difference is the number of partners the lady has. And so moving on now, we sometimes don't even give antibiotics when we put in IUCD if the patient is low risk for PID.
But what I'm saying is that actually I'm not saying that the IUCD is going to increase the risk, but it's her lifestyle. Because she is 22, she's young, and
Yes.
she's sexually active, and she's at
Yeah.
university. And that's
Yeah.
the point in life where you are more likely to be having
Yeah.
multiple sexual partners than just one. So
Yes.
that was the point. So now, what about, now she says she's sexually active. You know, progestins are good. COCP? A lot of people are telling us that COCP is just as good as Dinogest. So what's your opinion? Can we just
No,
give COCP?
That means you didn't listen to my
Premitha says
lecture,
no.
you see. So I said, COCP
No,
cannot.
I'm the
Because it
moderator.
increase your DIEs. So stay away from the estrogen component. Cannot.
Yeah.
Okay. Point taken. I listen. Okay. Okay. And for this girl, would you consider surgery? Anthony, would you consider surgery?
No, I'll go medical first because I want to reserve surgery for if it's really needed, as few as possible. You know.
All right.
Yeah.
Okay, so we move on to the next slide. Clarence, can we go to the previous slide first, please? So I read out the question and then I'll ask them to quiz. All right, so Aisha has come to see you 2 years later now. Okay, so she's now 25 and she's been having increasing amount of pain, and the pain is excruciating to the point that she's taken so much medical leave that she finds it difficult holding out a job. You examine her and you find that she has multiple cysts. She's got one on the right and one on the left. So she's got a 5 centimeter multiloculated one on the right and a 3 centimeter uniloculated one on her left. What would you do, Anthony? Oh, sorry, we go to the quiz first. Stop. Okay, quiz first, please. sorry. Oh, this moderator is terrible. All right, so everyone out there, I would just like you to poll. She's 25 and now she's got cysts on both sides. Would you operate, yes or no? So while you're polling, we will actually, 100%.
No lah.
People. So never mind. Okay, so while that poll is going on, it's actually quite distracting. So can we just get Anthony's opinion? Would you operate at this point? She's in pain and she's got cysts on both sides.
Yeah, so if I had given her Marina in the past, then I might now change to Vizen, because there are data to show that the long-term Vizen can reduce endometrioma cysts, you know. And I'll be very, very careful to do surgery on her because it's bilateral ovarian cysts. Although one is clear, the other one is more endometriotic. We also know endometriosis cysts start off as a clear cyst, then over time it becomes like a blood. And so she's very young. We don't want to damage the ovaries, reduce the ovarian reserve, and already endometriosis might be doing that. So I would really keep surgery to the last. If she is going to get married tomorrow, wants to have a baby in 6 months' time, maybe I'll do the surgery. But if she's still single, I'll try medical treatment first.
Or she might just get married. She might just get pregnant very easily and only operate, if necessary. So
yes,
yeah,
that's true.
Okay. So I guess would you just, so you guys are saying that let's start the SAN or Dynogest straight away for this girl and not operate and just watch and see if she's not desiring fertility straight away, right?
Yes.
yeah.
What are the long-term problems with the SAN? I mean, are there any? Most patients will come and say, on long term, every day must eat. I would be your worst nightmare because I would not be able to take daily tablets. So what can you offer me?
But they are probably multi-pharmacing with all sorts of multivitamins. So just put it in the same batch and take the Visan every day, because that would be the much easier thing to do. But I do agree that, some of them, don't like taking medication for some time. So I would say take it for some time. If you want a pill break, you take it. Go 2-3 months without it, see how you go. I mean, it's not a hard and fast rule that you need to take it month after month, year after year. So you want to take a break, take it. And then decide, come back for a checkup, decide whether you want to go back on it again, you can. So that's not a big deal. But you see, most of the patients, if they have been suffering from period pains, and now Visan has given them that quality of life. And these include a lot of my patients, where for the first time they see light at the end of the tunnel. If you tell them, and if you have even initiate this discussion about, let's try stopping Visan and seeing how it goes, they will look at you and ask, what matter? So I wouldn't even bother with them. But then you have the other boat that, would say, I want to take a break. And I'll say, okay, take a break and see how it goes. And then, we go from there. So that's fine. It's okay.
Yes. I'm with you. Yes.
Okay, I think we all think the same way. And the poll says that 74% of us actually will not operate on her on this point. So hopefully the 26% will join us as well to say, let's not operate, because I have seen horrific aftermath of women whose ovarian reserve has been so drastically reduced at a very young age, who's come to seek for fertility treatment. So, I mean, I do have women in their 30s whose AMH is below 0.5 picomole. So that's very, very low. So it's a very sad story. Okay, thank you for that. So let's see whether I've got any questions. So there is a question from the audience who wishes to know about the safety and the use of Visan and Mirena in a patient who has ischemic heart disease or stroke. With multiple risk, or a patient with multiple risk of cardiovascular disease who may not be a good candidate for surgery. So can we safely use these drugs in these women? They've got cardiovascular disease risks, or they have existing cardiovascular disease, or they've had them in the past.
Well, you can use progestogens for these kind of patients, but I would be probably thinking about putting her on the Mirena rather than going on an oral preparation, because she's probably got all sorts of other drugs, and we have no idea what her liver status. We don't want to add on to oral therapy, so I would go on to non-oral therapy and probably put her on the Mirena comfortably, easier for her.
Yes. Yes, I agree with that, because the serum level of the hormone will be much lower with the implant than the oral medication. This is where I think, if I'm given 5 minutes, I can share one case. So if you say that she has got the strokes and cardiovascular disease in the age group that you still have menstruation, it's a little bit unusual, because menstruating women don't get heart attacks, okay? And if they are that age, they have strokes and all those things, then they might have autoimmune disease, thrombophilias, or family history of cholesterol and all those things. So taking that into consideration, I had one patient who was about 30 years old, 30 to 36 years old, very active, goes to the gym, flew to the US, and then couldn't go to the gym, flew back to Singapore, still couldn't go to the gym, and then went to see her her chest, and then went to see the cardiologist, and then diagnosed they have a huge pulmonary embolism. Okay.
Wow. Okay.
And so she was on the warfarin and all those things. And when I said you have to check for thrombophilia because you're too young to just get a huge stroke like this, they stopped the warfarin for 3 days to try to get accurate blood test for thrombophilia test, and she had a TIA. Okay. So the blood test came back as severe lupus, very high doses. And so I said, progesterone and all those things are meant for patients with strokes, all the medical eligibility. But both the hematologist and the endocrinologist and the rheumatologist all say in her case, no. All right. So she needed surgery. So we didn't use even progesterone, Visan, whatsoever. She went for surgery, and we needed to do it in the multidisciplinary hospital, in the tertiary hospital, the hematologist, all those. So there will be some patients where, although we know progesterone is safe in the patient with strokes history, then these are the ones that you might still not want to use.
Okay. That is I feel very sad for that poor girl. What surgery did you do for her, by the way? Do you remember?
No, she had a hysterectomy. I sent her to Singapore General Hospital because we needed blood, needed hematologist, needed rheumatologist, needed a gynecologist.
Oh, okay. It sounds like a nightmare.
So I sent her to Singapore General Hospital.
All right. So I want to share a case that's come from my practice. So this patient, sorry, Clarence, it's still not this patient. Sorry. So this patient is actually, she came to me fairly young. She was, I think, only 19 when she first came, and she had an incidental finding of a 10 centimeter clear cyst. So it was 10 centimeters. I couldn't do it laparoscopically, Anthony. I'm sorry, I did open. So, so I took out the cyst, and lo and behold, it was actually an endometrioma, but it was a very early endometrioma. So she did tell me that because she came in and I saw fairly quickly, and we arranged for a surgery fairly quickly after that, and we managed to tease out of her that she does have dysmenorrhea, not very bad. She takes painkillers and they're still controlling, but she's got this 10 centimeter cyst and nothing else. So it's stage 1 endometriosis, essentially. Now, what do we do for her? Do we then put her on Dynogest long term? Now, for this girl, she's actually been on Dynogest for the last 6 or 7 years now, because after that, she found that the Visan really took away. After that, I gave her Visan. So then it really took away all her pain. So she was so happy. She refused to get off the Visan now.
A lot of them are like that.
So is there a role for us to just keep her on the Visan? Her mom is really concerned that her daughter's taking this hormonal preparation, right? But she kind of convinced her daughter to come off the meds. I'm, as a person who does fertility, I'm quite happy for her, to be honest, because I think that it actually will help to preserve her fertility for the future. I've already damaged one ovary. The other one looks okay. So do you think that in this that there is a role for long-term Visan use in ladies who's come in with early endometriosis?
I think in anything to prevent further endometriosis, because you know that the recurrence rate is really high. And how old is she again?
She was 19 when she saw me.
Yeah. So she's 19. The only issue that would come in here is I'm going to be worried about the bones, because the first 25 years of her life, you're building up her bones. So if I'm going to put her on long-term Visan, then I would have to look at her bones and see what's going on. So now, we tend to assume that it's just going to be drug related, but a lot of things can not make us, build up our bones to optimal level in the first 25 years. So talking to her about lifestyle changes and, calcium and vitamin D and all that, and just to stop smoking would also go a long way. But always keep an eye on the bones, but otherwise continue the Visan. I'm very for it. Yeah.
Yeah. Okay.
Yeah.
There's a question. Sorry, Anthony, did you have a comment?
I know in my conversation with all the Japanese during the conferences, they will, when asked this question, they will look at you blindly and say, "Why are you asking me?"
No, I think it's also because the Visan data is 7 years, right? So, everyone just says 7 years, and I just say, why 7? I mean, why not more?
That's where it started.
Yeah.
But the reassuring thing is, in the last meeting in Taiwan, the data is there's no breast signal, so there's no increased breast cancer to date. you know. So I think it's very reassuring.
So you just go on and on and on. Yep.
The bone
That's it.
density thing also, they said it's not super significant,
not
right?
No,
very-
because
yeah,
it's not.
it's not a lot. So
Yeah.
it's only important in the bone growing age group.
Yeah.
Once you're beyond that, it's not significant clinically.
Yeah, but I think just to pay attention and just get that other lifestyle measures in
Yes.
is an important thing to do.
Yes.
But more importantly, you have less pain. Look after your bones, so you have to balance things a little bit and go from there.
Yeah.
Someone has asked us whether we can comment on the role of danazol in the treatment of endometriosis and adenomyosis. I'm assuming they're not talking about the IUD. They're talking about oral danazol. Premitha, would you like to take this one?
I have never given. I know I've been practicing for the last 35 years. I have never given danazol because it's so bad in terms of side effects. So I'm not going to answer this question.
Okay. All right. We tai chi it to the Singaporean. Anthony?
Yes, I do agree that the oral danazol is not a very nice thing to take. And what is scary is that if you do get the side effect of voice change, it is irreversible. All right. And so all the other things like hair loss, pimples, weight gain, you can change that. But studies, some case reports that the voice change is irreversible. And so if you look at the graph just now when I showed, just oral danazol, the range of serum danazol is very, very varied, to very low to very high. So I think it's the patient's liver enzyme and all those things. But if you use vaginal danazol, all right, which is targeted to that area, the serum level is very, very low. And so I think I wouldn't really use oral danazol on a daily basis, like for months. I would rather use vaginal danazol. Despite saying that, I have used oral danazol as a third-line treatment for severely heavy bleeding. All right, so after using all these things, still doesn't work, still don't want surgery, then I give maybe about 10 days of the oral danazol, and it does stop the bleeding, and save the fella from a surgery just at a point in time. So I haven't used it for longer than that.
Do you have any experience in using vaginal danazol?
Personally, no. All right. The only thing is I hear it being very good from Professor Delphine Tan, and in Philippines they use it very, very prevalently. And then when I research on danazol, yes, the vaginal danazol in terms of loaded IUCD rings are very, very touted on. I have yet to really had the opportunity to use it once because most of the time I go Vizen or Marina and it works, and so then I didn't really have the opportunity to use danazol vaginally, so to speak. Yeah.
I guess danazol would be attractive to some of us here because of the cost.
Yes.
Because especially now in the government sector, I would say that the cost is rather prohibitive. So and using danazol, which is a cheaper drug, would be very attractive.
Yes.
So what kind of dosage are we looking at? That's a question too.
Yeah, and how to use it. So
are
I
we
like the
looking at,
question.
for the vaginal
Everyone's interested
danazol?
in vaginal danazol.
Yeah. So the tablet is 200 milligrams, and so you can insert one tablet, on a daily basis, And so really speaking, I always say go slow. You can do it once or twice a week, once or twice or 3 times a week, and then go on from there. Once the symptoms go away, then you just step down, What I hear from Professor Delphine Tan is they do it every day, but sometimes I feel every day is a bit difficult.
Over the top. OTT.
Yeah. But then again, the ring is there it's like a ring down there, they change every 28 days, So
it's like a Nuva ring.
Yeah, it's a Nuva ring, that's right. Yeah.
Okay. All right. So the danazol is about 200 milligrams.
It's the normal tablet is 200.
So once a week, twice a week, and then escalate from there until the symptoms slow down, and apparently there's no side effects. Yeah. I've recently met a patient who actually has voice hoarseness from danazol, and it's very sad. And I think honestly, it's my personal opinion, not that of OGSM or either of you, but it's my personal opinion that I really don't think you should use oral danazol for women. It is a crime.
I totally agree.
There are so many other drugs out there. Come on.
I so agree.
Okay, but that's my personal opinion. Please
that's mine too, so it's all right. Yeah.
All right, okay. Clarence, we are finally ready for the next one. I'm so sorry. Thank you. So we're talking about Anne now. Next, please. Anne is a 28-year-old lady who has come to see you. She's attained menarche at 13, and the periods have been just really getting very, very heavy and very, very painful for the past 2 to 3 years. It's worsening in the past 2 to 3 years. She's always been told that she had anemia and usually attributed to iron deficiency when she's gone for annual medical checks. Next, please. She's still not sexually active, and when you do your bedside ultrasound, she has a bulky uterus. Otherwise, everything else is normal. She's got an MRI done, and it looks like it could possibly be adenomyosis. Next, please. So again, one more quiz for our participants to make sure that you're still awake after we've been doing our little chit chat. So what would you do for Anne at this point in time? Anthony, why don't you take this one? What would you do for Anne? She's 28, well, she's got a bulky uterus, and she's symptomatic. What to do, what to do?
I think the toss-up will be between the painkillers and the hormones, you know. It really depends on whether she wants to treat the disease or whether she wants to treat the symptoms. I don't think looking at the MRI, it is that severe kind that we've seen. So she has some leeway to treat just symptoms, you know. But if you were to ask for my opinion, I would say to start with hormones to halt the process before it gets worse, because we all know once adenomyosis is established, it is not like a cyst where it's much easier to take out. When it involves the whole myometrium, it's very devastating to the uterus function in terms of menstruation and pregnancy.
So what about you, Premitha? What would you start for Anne?
No, I'm going to throw a spanner in the works and think, maybe I just give her progestin. You know, start off early.
Yes.
I think there wouldn't be any harm in doing that. Tell her that, you know what, this is going to get worse. You're only 28 years old now. You've got another 22 years before menopause. You know, let's just give you progestins and go from there and see how you go. And I think that would also help her because she's going to stop bleeding. Her iron levels are going to get better. Her pains are going to go away. And it doesn't have to be forever. She can stop in between, go back on it again. Maybe I'll be more inclined towards going on the Visan.
How about the Mirena? Would you fit a Mirena in this girl?
Yes, Anthony? that's another possibility. I can put her on the Mirena. I can even give her Implanon and see how that goes. So these are things that, you know, but again, depends on her psyche. She may not like anything going into the uterus at that particular time. So because, you know, we have a lot of women who don't want any interference with the uterus. I think getting her to a better place where she feels much better, everything goes much better, and then talking to her about long-term options would be a possibility.
Yes, I agree.
Do you think all progestins are made equal, Anthony? Do you think that they're all equal? Can I just give nortestosterone, the Depo-Provera? Are they all made equal?
I don't think so.
I don't think so. Why?
Because
I think you need to go look at the lipid profiles and all sorts of things. You need something that's safe for you,
Yeah. So the MRI did show some junctional zone things. So the Mirena would be a good option. You know, it's just next to it. Yeah. I'll try to stay away from depot at her age because of the black box warning and tends to give a lot of weight gain in some patients. You know, and then Visan, yes, is an option. But the downside is you got to take it every day. Whereas if she's agreeable to the Mirena, then maybe she's free from medication orally. You know.
Do you think the vaginal danazol will work for her too?
No, I don't think so because she doesn't have the pouch disease.
Okay, looks like our audience, I'm so sorry, it's not showing actually, but the audience agrees with us. They say that 77% of them would actually start progestin, and about 21% would start either tranexamic acid or analgesics. And I think the point that we're trying to drive across here actually is that maybe if you do suspect adenomyosis already, maybe to think about starting treatment a little bit earlier rather than symptomatic treatment, but definitive treatment just a wee bit earlier so that maybe we can save her some trouble. So anyway, the decision was made for Anne to start her on the oral contraceptive pill. And so then she went off and potted along. Next slide, please, Clarence. Okay. Unfortunately, she stopped taking the contraceptive pill because she was gaining weight. And her mom actually went off a nut and said that, oh my God, you're going to be infertile later in life if you start taking it. So she starts taking some Chinese herbs to help. So those Chinese herbs helped a little bit initially, and then then her bleeding became painful and heavy again. She's now 31, and she's found her life partner, but they're only planning to start a family in a couple of years' time. Next slide, please. So now when you examine her, there's a 12-week size abdomen, 12-week size mass per abdomen, and the ultrasound shows a globally enlarged uterus measuring 11 times 8 centimeters. Otherwise, there is no abnormality that is seen. Next slide, please. Oh no, go back, sorry. Go back, Clarence, go back. So sorry. Okay, what now? So now she's symptomatic, and she's still symptomatic, and now it looks like the adenomyosis has progressed, but she's still not wanting to have kids at 31. Now, if she was my daughter, I'll be saying, stop now, go and have children now. But okay, what do we do now? We cannot say that. We are not at a common state. Anthony, do you want to take this one first? What shall we do now for Anne?
I think she really should go on the Visan.
Okay.
Yeah.
Visan works for adenomyosis, or is it off-label?
It's off-label, but
Off-label.
Yeah, it's off-label. But for want of something to halt the endometriosis process, and hopefully if it causes the menstruation to stop, then we know that the micro-menstruation in the islands of stroma and the myometrium will stop, hopefully, Yeah.
Okay. There was a question earlier from one of our participants to say that, let's say this lady's got quite a big uterus. Is there, and then you say GnRH is good, right? But we can't give it long term. So is there a role to give it for 6 months and then start the Visan?
I think if the symptoms are very severe on onset, then you can relieve that with GnRH, but she will still have the hot flushes and the flare bleeding. And so it's a toss-up, whether you suffer now or suffer later, or you wait a while for Visan to work. I tend to feel that if you want to use GnRH, you should use it for a certain purpose, be it that to do it before surgery or to do it before IVF. But if you just use it and then not do anything, you'll be back to square one. So you're kind of wasting. And if what happens in the next time it doesn't work as well, then what's going to happen, you see?
Okay.
So now you have a 12-week size uterus. It's a big uterus. Now, let's say that this is just a topic for discussion, all right? So let's say that I want a Mirena to work. So now I'm looking at combination therapy. GnRH, shrink, put Mirena in. See how that goes. Or do I put in the Mirena, continue with Visan for a few months to make sure that the power inside that uterus doesn't actually shoot that Mirena out. But these are other options that we can actually try, isn't it? We can just play around with certain things that we have because just putting a Mirena in won't work for this girl because the Mirena is going to come up. So trying to play around with combination therapy is also something that we can think outside the box. The only thing is that it becomes more expensive for the patient, but these are certain things that we can do. We can try it out and see.
So do you think we give the GnRH, shrink the uterus, and then whack the Mirena inside?
Yeah, perfect.
What do you think, Anthony?
Yeah, I think it's reasonable.
Very interesting.
I can share with you when I was in Australia, Sydney, doing my fellowship. They put 2 Mirenas.
Yeah, I was about to say that there are people who put 2 Mirenas in. Yeah,
they put 2 Mirena because the serum dosage is not enough for the big uterus, so they put 2 inside.
So they put 2 inside, but that doesn't help you in terms of it being expelled, right?
Yeah.
Yes,
because
right.
It's big, so you're worried that when you put it in, it's going to be expelled.
But the 2 get entangled among themselves inside.
The trapped twin syndrome, is it like this? Okay.
No, but I think it's a big uterus. You have that expulsive force inside you, so whatever it is, it's going to come out. So I think we need to quieten down, freeze the uterus a little bit, and then put in the Mirena, so it has a higher chance of working.
I think if she had expelled the Mirena once before, I think moving forward, you should do the GnRH before you try another Mirena.
Okay. I have a question for the two of you. So this is a conundrum that I came across. I actually put in a Mirena for a woman with a normal uterus. There's no adenomyosis. I put it in for contraceptive purposes. That Mirena kept moving down, even though she was not having heavy bleeding or anything, but it kept moving down. So what do you do in that sort of situations where you fitted a Mirena, it's a normal size uterus. Oh, hello. It's a normally sized uterus. It's like, this is like the TV. It's a normal sized uterus and the Mirena has gone in. But now every month as you go along, because she's still spotting, but not bleeding, she's spotting, and then it's just traveling down. Now it's about 2 centimeters from the fundus now. What do you do? What do you do with this lady?
It's okay, because the Mirena, the papers on Mirena actually say that as long as it's somewhere in the uterine cavity, it works.
Yes.
So it's fine. Just leave it.
Yes.
Then what about that problematic bleeding?
She's always spotting every month. She's continuous spotting, or what happens?
8 months down the line, continuous spotting.
So every month it's continuous spotting. Then maybe no choice lah. Have to change
Take out lah, hor.
You could try giving her 2 weeks of estrogen. So you convert it to the
Good idea.
progesterone, and then see whether that kind of quieten down the endometrium. But if you still carry on, it could be the misposition of the Mirena irritating the endocervix that's causing that. Then if you want to save costs, you can bring her to theatre and put a hysteroscope in and use the grasso and push it all the way in and then leave it there.
Actually, I fitted that Mirena through ultrasound guidance. So it was straight at the fundus. It is there. And actually before that, she had a copper IUCD in, and it traveled down to the point that it appeared at the internal, in the external. Also, I had to replace it with the Mirena.
So
and then it traveled down
maybe there's
again.
some dynamics in that uterus lah. The
don't know
uterus
lah. I think it's the uterus
misshapen a bit
lah.
lah,
We just
yeah.
You
blame it on
use
the
the
uterus.
hysteroscope and you translocate the Mirena horizontally inside.
Translocate
Oh,
the
okay.
Mirena. Very
Yeah.
interesting. What's that?
So you need
Translocate. So instead of putting it this way, you put it this way.
you can only do it with the hysteroscope.
You wedge it. Then how do you take it out? Also,
You got to
hysteroscope.
do it with the hysteroscope again, yeah.
No
That's
need lah.
interesting.
Okay lah.
Okay. Sorry. Sidetrack already. Okay, Clarence, we're going back to the question
So
again.
Meilin, there is a question about endometrial cancer. I think we should answer.
Yes, okay.
Hi.
So there's a question here. They say that endometrial cancers arising from endometriomas, they are seeing more often now. Would the medical treatment for endometrioma prevent this endometrial cancers?
Anthony, answer first one.
Anthony, this question is for you.
Yeah.
Okay, the data for endometrioma going on to cancers, all the population data, all those review comes back to say that the general population has a ovarian cancer risk of 1 in 75 in a lifetime, which is about 1.3%. Of course, it's 1.3% where you're 60 plus. It's probably 0.2, 0.3% where you're younger. So if you do have endometrioma, then that 1.3% can increase to 2% or 2.2%. So it's a 0.7 to 0.9% increase. Okay. And it's usually increased to the cell type like clear cell and endometrioid. And the Japanese have done studies to look at how soon after a normal scan can a cancer appear. And the answer is 4 months. And so if you have a patient that you want to follow up who refuses surgery and she has endometrioma, then 4 to 6 months scan is probably what we should advise. And once the walls thicken up or the solid nodules appear a bit funny or the vasculature is increasing, then we should actually go in to take it out. So the 4 months to 6 months thing also ties in very well with the paper on cancer family history. So those patients with cancer family genes, BRCA1 and 2 and all those things, what is the screening protocol to pick up ovarian cancer? So they have done like yearly scan with CA1 to 5 and all those things. Then they move on to 6 monthly scan. So the latest is also about 4 to 6 monthly, where you can pick up earlier disease, but you still cannot reduce mortality, but at least you reduce morbidity by picking up earlier ovarian cancers. So I think we still do not understand why some become cancer, but we know that there is a slight increased risk of 0.7 to 0.9%. And the follow-up period should be between 4 to 6 months to make sure the cyst doesn't change.
For someone who
And I
had just
think
that question thrown at him, that was a very comprehensive answer.
Yeah.
I'm impressed.
But I
Okay.
think I make it simple. My answer is simple. You know, if something doesn't respond to medical therapy, then you need to think about cancer. It's very easy.
Very good.
Okay. that was very good. Okay. So, but is there a role in using CA125 to follow up these sort of patients? Like
Yeah.
doing, you know, and how often would you do your CA125, and at what level would you start getting alarmed?
Yeah. Again, CA125, I don't find that helpful because I think the ultrasound features are more important. And so, as we all know, endometriosis itself caused CA125 to go high up. And so, really speaking, I've seen adenomyosis causing CA125 to 900 over. And then, of course, everybody is worried. Then the CT scan shows no ovarian tumor. So, I'm not going to say the 9,900 is a sign that it's ovarian cancer. And so, again, I think CA125 is not a good marker. It's not a good marker.
I totally agree, but everybody is doing it, and I keep getting referrals for CA125 40. Don't know what to do. Okay, all right, can we just move on now? Okay, so next, now Anne is 38. She's married and she's had one child after having four first trimester miscarriages. Her periods are still heavy and it's getting more painful. She's tired of taking her iron tablets, it's everywhere. And now she has altered bowel movements during her menses, bloating, vomiting, with pain. She's completed her family and she's fed up. What do you do for Anne? Anthony, what will you do for Anne? Sorry. I keep picking on Anthony. Sorry. Premitha, what will you do for Anne?
I would put in the Mirena, but it also depends on how big her uterus is now, so that becomes a deciding factor. So 12-week size before, so now we are many, many years down the line, so I have no idea what her uterus size is at the moment. So, but if possible, I think Mirena would be the answer, and to continue that every 5 years till she menopauses. If the uterus is big, then I would try to probably give her some GnRH, shrink it, and then put in the Mirena. But that would be my line of treatment, and then see how things go. Yeah.
So yep. Anthony, would you put in Mirena through the hysteroscope, two of them, and wedge them like this? Would you do that? Let's say she has has a 14-week size uterus. Okay, let's put a spanner in words. We put it in between. She's got a 14-week size uterus. It's not huge, but it's not little. It's certainly out of the box now, because Mirena's only, you should use it for a uterus that's under 12 weeks. So now it's 14 weeks. So would you go in and put two and wedge them like that? Use GnRH, whack the uterus. What should we do? By the way, there's an active poll going, guys. So if you can just go to Slido and see what you're going to do, and let's see whether the experts agree with you. Yeah.
I think I will agree with Premitha. Try the Mirena first. And if you look at her whole life on endometriosis, the fight endometriosis, and if she had enough complete family, then we just take out the uterus.
Yeah.
What if she wants to conserve
the want to keep the uterus Yeah. That's what the women think keep the uterus. So try the Mirena first.
That is only if she wants, if she's tired of it and the uterus is a nemesis, then we take it out. But if she's still very attached to it, then we'll see how.
Is there a role for like just whacking a little bit of the uterus? So you just like cut out the wedge.
Yeah. So many techniques. If it is you want to be very radical, then the Osada technique is the one where you cut the uterus into half, like opening up a durian. Then you scoop out all the flesh and then you stitch it back. And so the Japanese are very good at this. They do it by open, they do it by laparoscope, and they've even shown pregnancy after this Osada technique. So it's radical. Yeah.
Can you describe this to us again? What the Osada technique? So where's the endometrium there? Where's the cavity?
So you literally have to bisect the whole uterus into half. So on the left half, you will see serosa, myometrium, and endometrium and cavity. Right?
Okay.
So you take away all the myometrium with adenomyosis, So you're left with some myometrium, some serosa, and then the endometrium. You do the same on the other half. Then you close out the endometrium, and you close out the serosa, and then you join back. So that's the Osada technique.
I feel stressed just
I know,
listening to this.
if you Google the YouTube, there are videos on it, and I just did one for the posterior one, and so it's very, very good in terms of pain relief, because she had about 5 centimeter posterior adenomyosis, and she's really complete family, but she still want to keep the womb. So we went in, we cut down the posterior just to the endometrium, and then so I know that I'm full thickness. So with the harmonic scalpel, it's actually easier to do because it's a bit curved, and you cut, and there's no smoke and there's no bleeding, you know. So you carve out that chunk of myometrium adenomyosis, and then you close it out. So you will have excess serosa, and so the idea is to close it like a double-breasted overlapping, you know. And then now with V-lock stitches, the tension holds as you stitch and tighten. So after surgery, 4 weeks, 6 weeks later, when you scan, the uterus is like back to normal size and pain everything on.
So
if
did
somebody
you
gets
upload this video
pregnant-
on your website?
So if somebody gets pregnant after this, it will be, I hope, a C-section?
You know, so yes, C-section, but I would say
Did you tie her tubes? Did you make sure that she's never going to get pregnant? Tie her tubes?
she refused, but I would
Oh
say
my.
I will reserve this mainly for those who really not thinking of pregnancy. Because if you're thinking of pregnancy, I won't carve out so much. You know, I'll carve out just like a pizza slice, and really got to counsel regarding the risk of rupture. Because as you saw the data, if it is just adenomyoma, you down-regulate them and you do the IVF, it's quite reasonable results. It's only when it's global adenomyosis, then you might not even get good results with down-regulation. So really speaking, we got to choose the patients and make them understand that there's a real risk of rupture.
There's 5% of our participants who will actually do what I call an adenomyectomy. So basically, they just want to do a pizza slice and cut it out. So there's actually 5% of people who will do that here. Wow. Okay. Fantastic. Now, there's someone who's asked whether there's any local experience in using letrozole in adenomyosis. Have either of you used letrozole in this for adenomyosis?
Yes.
And how would you use it?
Daily dose, you know, and then use it for 1, 2, 3 months, you know. Despite the fact that they say no side effect from GnRH, they do get some hot flushes. They do.
A lot.
Yeah, they do.
I don't wait for that 6 months to start my AdVac, okay? They just really suffer, you know.
Yeah, they do.
Yeah. So with the letrozole, you give 2.5 or 5? 5 milligrams.
2.5.
2.5 daily for like 2 to 3 months.
This was a patient who was allergic to GnRH, you know.
Huh?
Yeah. She had GnRH and she got bronchospasm, got to call the ambulance. Then we did a skin test and she showed the signs. And so we had to give her this one. And then I had to order GnRH antagonist, and she jabbed herself every day. So we use letrozole, we use GnRH antagonist, you know, yeah. And she's after hysterectomy. And after oophorectomy, and still pain.
Oh, poor thing.
No, but we later went in to excise the parametrium, then she got no more pain.
Oh, so she had deep infiltrating.
That's right.
Nodules, is it?
Yeah.
That's those kind of surgeries make me scared, but yeah, that's really good. They're very inspiring. But like I always say, it's like watching Roger Federer play tennis, and I think that you can play tennis as well. So it's really tough. So you did the Osada surgery laparoscopically?
Yeah.
Because you mentioned V-lock, you must have done it laparoscopically.
Yeah.
Fantastic. So when are you going to upload the video? Okay, can we go on to the case discussion, please? Enough of kacauing poor Anthony. Clarence, do I have any more questions? Am I done with my case discussion? Clarence has gone to get a coffee, maybe. Oh, I'm done. Okay.
Thank you.
All
right. So let me see if I've got any other questions that I wanted to ask you guys. Oh no, I think I've asked all the questions in the thing. Thank you very much, both of you. Is there any other nuggets of wisdom that you'd like to impart before we part? We'll start with Premitha.
Well, I think we do have to think about endometriosis with young girls with with period pains, with dysmenorrhea, and I always try to emphasize to the family that they have to come back for checkups, because I think that's really important, because they may not go on any treatment today. They may need treatment in the coming years, and trying to pick up anything early would actually go a long way for them.
Thank you. And Anthony, any nuggets of wisdom from you?
I'll say
We've received plenty lah. Dinosaur IUD, dinosaur vagina, what else?
Osada.
Osada technique. Oh, inspired. Okay, but any
nah,
further nuggets of wisdom for us?
yeah, always treat the patient. Don't treat the picture. Don't treat the CA125.
Yes,
Always listen to
very
the
true.
patient and treat the patient.
All right. Thank you. So with that, I would like to formally thank our two wonderful speakers. I owe you guys dinner when the MCO leaves. Okay. And when Anthony is able to travel to Malaysia, I promised him a nice dinner as well. So
All right.
I have nice dinner and a nice bottle of wine, maybe more.
Oh,
All right.
thank you so much.
Thank you very much.
Thank
I've really
you.
enjoyed this session. Thank you for being so wonderful and so generous with your time, both of you.
No worries.
And I've certainly learned a lot. And for the rest of you, thank you for joining us today on this Saturday afternoon. It's really hot outside in Malaysia. I don't know what it's like in Singapore. But we already hope that you've benefited from this session as much as I have. I would like to record my thanks to our sponsors once again, Bayer and Dr. Shield, without whom this webinar would not have been possible. I also would like to record my thanks to the OGSM Secretariat for coming into work on Saturday to make all this happen. And Clarence, who runs our webinar platform, and his team, who has been working hard all day. Thank you very, very much.
Thank you.
Our next, the next webinar series that we will have will happen in October. On the 3rd of October, we'll be having a webinar on medical legal issues again about the legalities of common obstetric practices that we do every day. So we'll be able to get some lawyers and some judges on board to speak about that. And the next one that we have also will be the following one on the 17th of October on World Menopause Day. Will be a webinar on menopause, and this one will also be run by Dr. Premitha, because
well, I'm trying to make it a debate, so let's see how it goes. Trying to make it an international debate. So
okay. So if all else fails, we'll call Anthony again, because I'm sure he'll be on it. Okay.
It's been fun.
Okay. With that,
all
I'd like
right.
to close the session. Thank you so much. I've had so much fun. Thank you very, very much, and to all of you, thank you for joining us, and I hope you'll join us again. There is a feedback form that please, if you could help us to fill out, we would be most grateful. And this webinar will still be available through registration for the next 1 month for all those who have missed out. Thank you very, very much, and goodbye.
Okay, goodbye. See
Bye.
you all.
Bye.